Thank you for asking me to give this talk at the 5th Asia Pacific meeting. It's a great pleasure to do so. The title I was given is Cognition and Behaviour, but as you can see from this slide, I've expanded the title to include making sense of mental ill health in people with Prader-Willi syndrome. I hope it'll become apparent during the course of my talk why I have done that. But I've also had the subtitle A Research Journey, because what I want to try and do today is to take you through a journey that I and many others have gone through, both in terms of research and also clinical practice, to try and better understand the problems associated with the mental ill health of people with Prader-Willi syndrome. And this includes both the behavioural difficulties that you will be familiar with, as well as some of the mental health problems such as a mood disorder or serious mental illness. But I want to start my talk by really acknowledging right at the beginning that people with Prader-Willi syndrome have many strengths, and these are well illustrated on the IPPWSO website and through social media, and I'm sure also on your own websites. However, the objectives of this talk is really to help provide an understanding of why people with Prader-Willi syndrome are at risk for particular difficult behaviours and mental ill health in general, to consider the cognitive profiles associated with Prader-Willi syndrome and the impact this has on behaviour and mental ill health, and then finally to discuss the implications of the above for prevention and treatment. But to start with, I want to take a bit of a step back, and I want to look at what we mean by mental health and mental ill health. And a lot of this work has been undertaken by the World Health Organization. And there's really a strong analogy here with physical health. When we think about being physically healthy, we don't think that this is simply because you're physically healthy because you don't have a physical illness. We recognize that being physically healthy is also something about being able to take good regular exercise and being able to do those things that we want to do as part of our life and in society. Well, mental health is very much the same. It's more than the absence of a serious mental disorder, such as anxiety or depression or a serious mental illness. It includes, and well, it's best described by the phrases in this slide taken from the paper that is based upon the WHO work. It's about being able to live in a dynamic and stable state in the context of the environment where we live and the social life that we lead. And if you look at some of these phrases, you can see how it is that people with Prader-Willi syndrome may certainly have some difficulty. I mean, for example, being able to cope with adverse events and function socially. So this is the definition of mental health I'm going to use, which covers both the behavioural problems that we see in people with Prader-Willi syndrome, as well as the more classical mental health problems such as depression or perhaps being high and having something like mania or hypomania. But the starting point, I think, in understanding these difficulties is to recognise that people with Prader-Willi syndrome have a delayed and atypical brain development. And this really has two very significant effects. Firstly, it impacts upon the development of cognitive abilities, which means that for people with Prader-Willi syndrome, they may be less able to develop and have, if you like, an accurate model of the world and to interpret the behaviour and feelings of others, or to respond efficiently and effectively to the challenges that we all face on a day-to-day basis. And I'll come back to this in a moment. But I think there's a second area that's really important here, and this relates much more to the hypothalamus and a small area of the brain that I think most of you will be familiar with and is critical in understanding the needs of people with Prader-Willi syndrome. And that's having really an impaired ability to regulate behaviour and emotional states in response to the needs of the body and the demands of the physical and social environments. And here I've given three examples. The first is a very obvious one, and that is food intake. The body needs to match how much it eats, so how much energy it takes in, with how much energy it requires on a day-to-day basis. If it takes in too little food, then of course you lose weight. And if you take in too much food, you put on weight. And it's clearly, this is one area that is a major issue for people with Prader-Willi syndrome and results in hyperphagia. And I'll again come back to that issue in a moment. But also I think it is about being able to regulate according to the social demands in an environment. So the ability to actually respond to the emotions and behaviours of others in an appropriate and effective way. And the third example I've given is a very obvious one, the ability to regulate your temperature or to maintain your temperature regardless of what the environment is. So if you're in a cold environment, you may shiver to maintain your temperature. In a hot environment, you may sweat in order to make certain that your temperature doesn't rise excessively. So in these two areas of cognitive function and in the ability to regulate, both in terms of the internal state and internal needs of the body, as well as the demands of the environment, are really two areas that are very important to understand with respect to the behavioural and mental health problems of people with Prader-Willi syndrome. What I'd like to do now is just to reflect a little more on some of the cognitive problems that are experienced by people with Prader-Willi syndrome. And one of the most obvious areas is intellectual functioning, and I'll come back to that with the next slide. But I think actually what's more important than that is these, what are sometimes referred to as higher order cognitive abilities, things like social cognition and executive functioning. So these include the skills that are necessary to be able to live an independent life, particularly as an adult. And these skills become more important as you get older. So they include things like theory of mind, that's the ability to recognize the thoughts and feelings in other people. But it also includes, for example, the ability to plan, the ability to switch your attention from one task to the another, the concept of time, and so on. But also, people with Prader-Willi syndrome have difficulties in what one might call attainments. That's the abilities such as numerical skills, reading, and language development. All of these may be rather subtle and not immediately obvious, but they are there. But they also have difficulty retaining these skills if they're not repeatedly practiced. And for some people with Prader-Willi syndrome, particularly for those with the UPD form or disomy form, they may have particularly slow processing speed. So it's not that they don't have the ability to understand, but it may take them time to process this information in order to then respond to it. But just a note of caution that many of the studies that are referred to in this review that Joyce Whittington and I did a couple of years ago, many of these studies were done some years ago, or done at least on populations of people with Prader-Willi syndrome who are now adults. And they were from an earlier generation, and they may not have had the level of education that a younger generation might now expect. They may not have been on growth hormone from a young age, and so on. So we may find that in this younger generation who have had perhaps the advantages that the older generation didn't have, that these cognitive impairments, whilst I think they'll still be there, may not be as significant. And so there's just a note of caution there. Another point I think that's very important to make here, and I illustrate this with IQ. So as I mentioned, the IQ, the full scale IQ of people with Prader-Willi syndrome, if you look at a population of people with Prader-Willi syndrome, usually falls around 60. And in the general population, it is around 100. But as this graph illustrates, it's known as a normal distribution, that of course within any population of people with Prader-Willi syndrome, there will be a great variation. The vast majority will fall either side of this IQ score of 60, but there will be some with much higher scores and some with much lower scores. This may be of significance, for example, in that if a country allocates resources on the basis of having an intellectual disability and someone has an IQ score of 70, This may be taken as an indication that they don't formally have an intellectual disability, and this can certainly be problematic in achieving the help that you need. But I think the most important here is to state that there is this variation across a population, and one person with Prader-Willi syndrome may be very good in one area of cognitive functioning and rather poor in another, and the opposite may be true for someone else. There are, of course, some differences depending on whether you have the disomy or deletion form of Prader-Willi syndrome. I think the other important point to make about cognition is that the impairments that are consequent upon difficulty in terms of cognitive function may not always be apparent, and may only come apparent under certain circumstances, perhaps where the person is being stressed in some way or other. And of course, stress may further impair their cognitive abilities. So these cognitive impairments that are well recognized now in people with Prader-Willi syndrome clearly have impacts on learning and level of education and the attainments that people achieve in terms of numeracy and so on, but also seems to have implications in terms of the ability of the person to maintain those skills over time. But also it affects the person's ability to reliably interpret and make sense of the physical and social environments. And this is very much based upon some very complex work by someone called Friston and many others that argue that the brain constructs a model of the world, and it constantly updates that model of the world through its senses. And therefore it's monitoring for change on a minute by minute and hour by hour basis. And what I think one can reasonably say is that people with Prader-Willi syndrome may have a different and incomplete model of the world because of the difficulties that are described earlier in terms of, for example, recognizing and being able to reliably interpret the facial expressions and intentions of others. But there's also this other aspect, and that is the ability to respond to circumstances and make decisions in an efficient and effective way, because their understanding of the world may in some way be different and impaired. So every so often in this talk, I'm just going to sort of, in a sense, pause for a moment and just try and make some what I've called key points. And I think the key points so far are that first, that good mental health requires the necessary cognitive, social and functional skills. But it also requires the ability to regulate emotional and affective states, so that's mood states, in the context of the social and physical environments. We need to think of mental health as a dynamic process in the context of an inevitably changing environment. Now, there's a different way to look at this, and that is in terms of the studies that have been done in many countries and over many years, that to try to answer the question, what are the particular behavioural and mental health problems that are associated with Prader-Willi syndrome, and if you like, are particularly prominent in people with Prader-Willi syndrome. The most obvious one is the emergence of hyperphagia in early childhood, which I think one can reasonably say affects 100% of people with Prader-Willi syndrome, although clearly it varies in degrees. And some families will say we have to lock the food cupboards, and other families will say that hasn't been necessary. And it may even vary in one individual over time. The other areas, I think, are repetitive and ritualistic behaviours, sometimes referred to as obsessive-compulsive behaviours, emotional or temper outbursts, which I think can be extremely problematic, severe skin picking, what I've called here non-psychotic mood disorders. So this means perhaps having a rather vulnerable and fluctuating mood with periods of feeling low and other periods of feeling high, or more serious psychotic illness, which can occur in people with, particularly in people with the UPD form of Prader-Willi syndrome. And I will come back to that a bit later. So as I said at the beginning of my talk, my hope is that I can give you insight into our understanding of some of these problems experienced by people with Prader-Willi syndrome. And by giving you that insight, you can match that with your understanding of your son or daughter with Prader-Willi syndrome. It's sort of bringing these two groups of information together that leads to developing strategies that are tailored for the individual, but based upon a sound understanding of what we know about these problems. So what I'm going to try and do is to tell you, if you like, what does research say about hyperphagia, the emotional outbursts, the skin picking, and mental illness. And I've included mental illness in there because mental illness presents as a change in behaviour. And I think one of the important messages that I will come back to is that when someone's behaviour deteriorates or you get new and unexpected behaviours, you always need to ask the question why. So I'll return to that in a while. But I'd like to start with hyperphagia and ask, what do we understand about this behaviour of overeating? This slide shows a weight graph here on the left of the first person I ever saw with Prader-Willi syndrome. And at age 18 in 1981, she left the family home to live in a hostel for people with intellectual disabilities, where she put on weight at an alarming rate. And I was asked to see her. I was a trainee psychiatrist at the time in London, and I hadn't heard of Prader-Willi syndrome. And when I spoke to her parents, they said to me, of course this happened. We said to the staff at the hostel, you need to lock the food cupboards and you need to control our daughter's access to food, because if you don't, she will eat too much. And this observation really led to the first study that I was involved in which we asked people with Prader-Willi syndrome to come in and we gave them free access to food for an hour, and we compared their behaviour with that of a group of people who didn't have Prader-Willi syndrome. And what this shows, this is the group who didn't have Prader-Willi syndrome, looks at people's rates of eating over that hour whilst they had access to sandwiches. And as you can see, and as I think you would expect, what they did is eat quite rapidly for a while because they were hungry, and then slowly but surely they stopped eating because they felt full. Whereas this did not happen with the people with Prader-Willi syndrome. And the vast majority of them went on eating even though they clearly had had more than enough food to meet the demands of the body. This led us and to others to argue that really one of the fundamental problems about Prader-Willi syndrome is that there's an abnormality of what is referred to as the satiety cascade. Satiation is the state of fullness that stops you eating, and the body has a number of feedback mechanisms that, if you like, communicate between the brain, the gut and the brain, so that ultimately one's behavior changes and one stops eating because one is now satisfied and satiated. One of the, I think, advances that we're seeing in general is that there's a much greater understanding now of this satiety cascade. And in this diagram here, I've got the brain, and then down here, the gut and fat cells. And what people know is that there is a feedback with chemicals that are secreted from the gut cells into the blood, as well as feedback through the vagus nerve from the gut to the brain, that is all part of this satiety cascade. And it's something in this process that is clearly faulty, presumably at the level of the hypothalamus here in the brain, that is important for us to understand in people with Prader-Willi syndrome, because if we could correct that through treatments of one sort or another, it might help people with Prader-Willi syndrome better regulate their eating behaviour and their food intake. But at present, I think we don't have those treatments, although, as many of you will know, there are a number of trials that are ongoing at the moment. But the second series of key points are here. I think it's really important to state that hyperphagia is a consequence of a biological impairment in the ability of the brain to limit energy or food intake in line with energy needs. I think we know this from brain scanning studies that have shown that the brain in people with Prader-Willi syndrome responds differently after the person has eaten, and therefore they are not able to regulate their food behavior. This is not someone with Prader-Willi syndrome being stubborn or difficult. It is that the mechanisms that would normally allow people to regulate their eating are not effective and are certainly very inefficient in people with Prader-Willi syndrome. Interestingly, I think treatment trials for hyperphagia are targeting different biological pathways, the various pathways I showed you in that previous slide. But at present, I think treatment is really one of management. It's about primarily preventing obesity, food security. Also, I think it's important to state that food security may bring other benefits, such as reduced emotional outbursts. And I think that's because food security brings some consistency into the person's life, and also some reassurance in the sense that food will be available. So it's both emotional security as well as physical security. I want to now move to temper outbursts or emotional outbursts. And I want to just give you some examples from two studies. The first of these by Rice in Australia, in which she surveyed 101 families of children with Prader-Willi syndrome. And here's some of the summary of the data that she identified. First, she identified that this particular behavior seems to get worse in adolescence. But also, she and other studies have shown that these outbursts tend to have a very characteristic onset and also a particular course over time before finally resolving, and often resolving with great distress and with tears. But they may be triggered by what's called here goal blockage, so some frustration because the person wanted something and it's not possible, or what the person sees as some injustice. They were promised something and it's no longer possible for them to have it, and also because of some change and the difficulty they have in coping with the change, in coping with the cognitive demands that come with change. She also looked at what people did under these circumstances. And in essence, what she found is that trying to give the person space and distracting them were really the only things that were reported to be effective at all. And whilst medications such as the ones listed here were used, they're really of limited value. And I'll come back to that when reflecting on treatments a bit later. This is the second study by Kate Woodcock in the UK, and she looked at a small number of people with Prader-Willi syndrome in great detail. And essentially what she found was that you got an increasing risk and increasing number of temper outbursts when there was a cognitive challenge that came with the need to switch attention from one task to another. And that these temper outbursts increased when there was unexpected change. And I think this sort of observation will be very familiar to you. But essentially what she's arguing is that change in the environment brings the requirement for cognitive abilities to cope with that. And that in itself gives rise to the emotional outbursts. Now I want to move to something rather different, and I want to show you some results from a trial that we did of something called vagus nerve stimulation. And the importance of this is all these interventions, whether medication, psychological, or something like this, if they show benefit, that's not only important because it provides the potential of a new treatment, but it's important because it's telling us something about causation. It's telling us something about the underlying mechanisms that cause these problems. Now, vagus nerve stimulation is something that's been used a lot, usually from an implanted device, a bit like a pacemaker, to treat epilepsy. And we originally did a study using the implanted vagus nerve stimulation to see if it would help the overeating behavior, but it didn't. But in that study, 2 of the 3 people who took part with Prader-Willi syndrome reported to us that after some months of stimulation, they noticed a marked improvement in their behavior. And the parents noticed this, and it was clearly very, very real, to the extent that the 2 people who had these improvements have continued with the vagus nerve stimulator in place and active, and they've now had it for nearly 10 years, and their behavior has been very, very much better. But this study is the second study we did and uses a different type of stimulator, which is worn on the arm, as shown here by one of our participants, with a wire that goes up to the left ear, where there's an electrode in the left ear which stimulates something called the auricular branch of the vagus nerve. This is worn for a particular period of time each day. In this case, it was for 4 hours. And 6 people took part in this study, and 5 of the people completed it. Now, we do know that vagus nerve stimulation takes many months before it has an effect when it's used to treat epilepsy. So we anticipated here that if it was going to be effective, they would need to continue using it for a long period of time. What these bars show is the mean number of temporal outbursts per day, and the white bars are in the period before the VNS was being worn and was being switched on. And then the green bars after that are 3-month periods up to 1 year. So that's the first 3 months, then 3 months to 6 months, 6 months to 9 months, and 9 months to 1 year. And over that period of time, the participants were wearing their vagus nerve stimulator, and it was switched on for 4 hours a day. And what you see in 4 out of these 5 people, not with this person, is a marked reduction over time of their temporal outbursts. And again, this was really very marked, and it has really made a significant change to their lives. And 3 of the 4 people continue to wear their stimulator 4 hours a day and continue to do very well. The next slide just shows some of the descriptions that people gave. For example, one informant said, referring to one of the participants, before you couldn't challenge him on certain things, but now you can, and he's prepared to sit and listen. And another person said, she just seemed to accept the change. A few weeks ago, I don't think she would have, and so on. Now, this is early days, and clearly much more research and further trials are needed, but it does seem potentially very positive. And as I mentioned earlier, it is also telling us something about what causes these outbursts, or if you like, what is the impairment that underpins these outbursts. And this is sort of illustrated in this slide that is taken from the work of Kate Woodcock. And I just want to take you through this before I then move to look at skin picking in some detail. If you like, you've got the genetics of Prader-Willi syndrome. And as I mentioned, that affects the way that the brain develops. And one of the problems they have is a deficit in being able to switch attention from one task to another. In the environment, something comes along, some unexpected change, and that causes very marked physiological arousal, much more marked in someone with Prader-Willi syndrome than it might do in you or I. And what Kate Woodcock argues is repetitive questioning may be used by the person initially to try and manage the situation, buy a bit of time, if you like. But essentially there gets a point which is no longer possible to control it, and a major temporal outburst occurs. So by looking at this model, you begin to say, well, how can you help it? Well, I think one is, then this is Kate Woodcock's work, is looking to how you might prepare and help train people with Prader-Willi syndrome to cope better with change. But another way is to, can you change this dysregulation, this emotional dysregulation experienced by people with Prader-Willi syndrome? And can you do that either psychologically or through something like vagus nerve stimulation? So at present, the situation is that I think we're still limited in our treatments of emotional outbursts. I think there's prevention. In other words, trying to create an environment which is more routine, is more predictable, and in which the person with Prader-Willi syndrome feels safer. There is the perspective too of something called applied behavioural analysis that argues that behaviours such as temporal outbursts get shaped and are maintained by certain the responses of others. And I think this is very important, that behaviours don't have a single cause. It may be that emotional dysregulation is important, but also these behaviours are shaped by the way that people respond to them. And that part of the importance of trying to help these behaviours is to look at patterns when these behaviours occur, how people respond to them, and so on and so forth. I think food security is another way of helping to reduce some of the behaviours. And I think also what's very, very important is that families work to develop a consistent approach to managing these outbursts. Whilst ideally you want to prevent them, a second strategy is in a sense to more effectively manage them. And that's having an agreed approach, something that can be agreed with you as well as the person with Prader-Willi syndrome when they're in a calm state to discuss these things. But there are many challenges. I've listed some categories of medication here, but I think by and large, the use of medication is fairly limited. Skin picking. Here I've just called them body-focused self-harming behaviours because I think it's more than skin picking. It may include, for example, rectal picking. But I think what we know about skin picking at present in people with Prader-Willi syndrome, that it seems to have very particular characteristics, specifically picking at existing lesions and often particular parts of the body, the face, the arms, and so on. But we also know, and I'll show you some data in a moment, that the rate of skin picking may be influenced by environmental circumstances, and also I think by mood state. There are certain factors that I think we now believe may predispose to this behaviour in people with Prader-Willi syndrome. One is sometimes referred to as sensory hunger, the need for stimulation. And for the person to feel stimulation, it may need to be more marked and more severe than perhaps it would be for you or I. I think the fact that they have a high pain threshold means that they don't have the negative feedback that comes with skin picking. If you and I started skin picking, the pain that came with that might stop us. Also, people might argue, and I think this is questionable, whether the tendency to routine and obsessive behaviours is also a factor in maintaining the skin picking. This is just some data from someone called Scott Hall, and this is data on 8 people with Prader-Willi syndrome, and he looked at the rate of skin picking depending on the circumstances, on the environmental circumstances. So these first 2 bars where skin picking was quite high, the person was either being ignored or was alone, whereas in these other bars they were engaged in activity or with other people who were interacting with them. The point being is that whilst having Prader-Willi syndrome brings this predisposition to skin picking, whether it occurs or not may be very dependent upon environmental circumstances. So one approach to treatment is changing the environment, is if it seems to occur when someone has limited activities and limited contact with others, are there things you can do, activities that you can help the person engage in, which will then reduce the extent and nature of their skin picking. So skin picking in people with Prader-Willi syndrome, I think, is best understood as this interaction between a biological vulnerability and physical and psychological factors and environmental circumstances. And again, just like with temper outbursts, something called functional analysis, this is the same as applied behavioural analysis, may be important because particular factors may be making the likelihood of skin picking worse or may even protect against it. And that may be different from person to person. I think one needs to treat what I've called here comorbidities, such as mood disorder, because I think when someone with Prader-Willi syndrome, when their mood is low, that may aggravate the skin picking. You may look to environmental changes that I described earlier. It may be important to use topical treatments to skin that might minimize itch and that sort of discomfort. And of course, there have been studies, one example of which is the use of something called N-acetylcysteine to see whether that might help. These studies have all been what's called open trials. And I think at present, whilst they would argue the findings are positive, as yet we really don't fully know the place of medication in the treatment of skin picking. Now, I now just want to shift just to look at what I've called an abnormal mental state, or the onset of psychotic illness in someone who was aged 18 at the time with Prader-Willi syndrome and had the uniparental disomy form. And I do this because it demonstrates how a mental illness presents with a change in behaviour. In this case, the person became more anxious. They became what here I've called bewildered. They were confused, but it was more a sense of really not knowing quite what was happening to them. And they started talking incoherently. They were, for example, in this case, referring to blackmail. And initially, this occurred over a period of some hours. Initially, the doctors who saw him thought that he might have what's called a confusional state due to a physical illness, and they actually treated him with antibiotics. And really things didn't improve, and it deteriorated further. And I've described some of the behaviours that were observed by those people that were looking after him. In essence, this is an example of a really rather sudden onset of a psychotic illness. The point being, it was a marked change from what was normal for this person. He has subsequently been treated with an antipsychotic medication, in this case aripiprazole, and has generally done quite well. This now was some years ago, and I think he's had 2 brief relapses since then, but generally has done well. And it's very important to state that whilst obviously it'd be better if someone didn't develop such a problem, there are treatments for this. This slide is taken from an early study that we did, in which we looked at a whole population of people with Prader-Willi syndrome. And as is shown, those with UPD here on the bottom. The red shows the proportion who had a history of an episode of psychosis or were mentally unwell at the time we saw them. And the rate is higher compared to those with the deletion. Those with the deletion are at risk for it, but not to the same extent as people with disomy. And the importance about that is it does tell us something about the underlying mechanisms that must be causing psychotic illness, particularly in people with disomy. So mental illness in people with Prader-Willi syndrome really presents with a deterioration in behaviour or the onset of new behaviour. It's usually acute, but it can be gradual, and it's associated with abnormal mental experiences. And the treatments initially include medication. There isn't time now to go into this in any greater detail, but I just want to summarise some of the key points here. That difficult behaviours may occur for different reasons, but when behaviours are a problem, ask yourself, is this what we have seen before, or is it different? If this behaviour is new or has become much worse than it has been, ask why. And then ask, is there any evidence that the person with Prader-Willi syndrome might have developed a physical or mental illness? So do they have abnormal mental experiences? Or do they, for example, have physical symptoms suggesting a physical illness? And as you'll know, vomiting or complaining of pain in people with Prader-Willi syndrome is an indication of severity. Now, over the last few minutes of the talk, I just want to really try and summarize and take you through the implications for intervention. And this slide really tries to summarize what I've been talking about, that the genetics of Prader-Willi syndrome leads to atypical brain development, and that particularly affects the ability to regulate behavior and mood, and this is often referred to as something called homeostasis, but in the context of changes in the environment. It leads to impaired cognition and in understanding and the ability to respond to change. And particularly in people with UPD, it increases their risk of particular mental illness. But also, these things occur in the context of the environment and change. The behaviours may be reinforced and maintained by circumstances in the environment. So interventions, you can see, can be at the environmental level and include psychological interventions and early interventions, or they can be at the more biological level, such as the use of medication or something like vagus nerve stimulation. And it's this that I just want to examine before coming to an end. So your interventions, I think, should be developed based upon your understanding of Prader-Willi syndrome in general, and your understanding of this particular person, whether it's your son and daughter or whoever, this particular person with Prader-Willi syndrome. So at the environmental level, what you're trying to do is to construct the environment that helps the person understand better what is going on and to reduce the uncertainty that they must experience if their understanding of the environment is impaired. So this might include things like structured timetable, visual support, because people with Prader-Willi syndrome can generally process visual information better, the use of the way you use language, and perhaps the use of slightly more concrete and specific language. People with Prader-Willi syndrome will have trouble with the use of irony, for example. And whilst they will certainly have a sense of humour, that sense of humour may be more subtle, may be more concrete, and that the subtleties of irony or of humour may pass them by. And the importance of food security. I think the psychological strategies may include strategies to help them manage change, strategies that recognize that you follow when you recognize that someone's getting upset, that may enable them to contain and control their outbursts or to reduce their skin picking. This may include the approaches of applied behavioral analysis. It may, I hope, in the future include strategies in terms of early intervention, such as helping people with Prader-Willi syndrome learn how to cope with change. It may include medical treatments, certainly treatments of physical or psychiatric problems that are known to respond to treatment, and such as physical illnesses and sleep apnea, for example, which certainly causes irritability, or treatments of serious psychiatric illness. I now want to end by just looking at the future a little bit. And I think the future is a positive one. I think firstly, within the field of social support, we need to know better and learn better how people can deliver support to families, or if someone moves out of the family home into a residential setting, how we deliver support in a way that optimizes life for people with Prader-Willi syndrome and minimizes the chance of these problems developing. We need informed and well-resourced social care if people do want to move away from home. And we need educational and later opportunities in the form of employment, in line with the United Nations Convention on the Rights of People with Disabilities. There are trials for potential new treatments for hyperphagia. There are issues around treatment for other behaviours, such as the VNS trial, the use of medications and psychological approaches. And then there's been this interesting observation about whether something like oxytocin, the hormone that we know that is deficient in people with Prader-Willi syndrome, may, for example, improve social functioning, among other things. And I'll come to that in a moment. I think we are seeing developments in what's referred to as personalised medicine. And there is some work that has looked at the question of pharmacogenomics that may guide the dose of medication that is given. We know that we all have different genetic backgrounds, and we metabolize medications in different ways. We know that the genetic variation is the same in people with Prader-Willi syndrome, almost the same as it is in the general population. And it's likely that in the future, that approach may help guide the use of medication. Although my own feeling is that it's premature for people with Prader-Willi syndrome, because as yet, we still don't know when medication should be used and when it shouldn't be used. But we may also have developed ways of identifying who is going to be sensitive to particular treatments and who won't be sensitive. And I think also the application of neuroscience, developments in how you study the brain, are going to be really, really important. Just I mentioned oxytocin, and the interesting thing about oxytocin is that it's been explored for a number of issues in Prader-Willi syndrome, starting with the failure to thrive postnatally in the newborn with Prader-Willi syndrome, initially studied in a mouse model of Prader-Willi syndrome. But it's also been used and claimed to help with issues around social functioning, although this is debated and is, I think, still not entirely clear. And it's also been claimed that it might be helpful with the hyperphagia. And again, the results are a bit mixed. So my final points here are really that the prevention and effective management of problem behaviours requires understanding. That there are specific treatments, but at present those treatments are really rather limited. And that I think the main approach is still about how you modify the environment and your approach to the person with Prader-Willi syndrome to limit the risks or that these problems will occur. And I think much can be done. I think that we should also remember that cognitive impairments that I've described makes the world more uncertain for people with Prader-Willi syndrome. So again, it's about changing the environment to help compensate for that. Also, psychiatric medications may have their place, certainly in treating mental illness, but they need to be used with caution and guided by diagnosis. I think developing psychological interventions, new treatments for some of the specific symptoms like emotional outbursts and skin picking are being developed. And I think more informed approaches to support really suggest that there is a positive future. It may at times seem very slow, and it probably is very slow, but there are developments. And I would like to think that in the future, some of these problems will be a thing of the past. I hope this talk has helped you understand these issues, and I'd be very pleased to take any questions and hear any comments that you might have. Thank you again.